Thank you very much. So, role of stents below the knee. These are my disclosures. Endotherapy, obviously, we all know that the angioplasty has poor morphologic failure, although clinically there's good results. And we have to break it down into early failures and the late failures. And the early failures include a recoil and dissection that really is underappreciated. If you look at this patient over here, the perineal artery has some disease in it. The other two vessels are occluded. Perineal artery was balloon dilated, as you can see here, and it looks, reasonably good. And so we went after the posterior tibial artery in this case. And after the posterior tibial artery was recanalized in angioplasty, which didn't take very long, you can see we lost the perineal artery in the interval. So the thought was, okay, was there a plaque shift up at the top or not? So we, double wired it and reballooned it, and now it looks good. And 10 minutes later, we're losing the posterior tibial artery. Again, not an unusual situation. And this one, you can see it's not really plaque shift because it's more distal to it. So that was fixed, and now we can see that now we're losing the perineal artery again. I mean, it's just a back and forth, back and forth. And here you can see that it wasn't a plaque shift, but it actually was a plaque in the perineal artery itself that kept recoiling. And so it was stented, which what we should have done to begin with. And drug-eluting stent. So this is not an uncommon situation. So now if we look at the post-angioplasty vessel injury cascade from minutes to months, early on recoil and dissection predominate. And of course, then you get the inflammation, which is a matter of hours, all the way down to the cellular proliferation and migration, which is a typical neointimal hyperplasia. Now, for recoil and dissection, the solution is mechanical. These really is pharmaceutical and biological. So it's got to be a combination of those two. And when you look at it, drug-eluting scaffolds are the way to go. Now, DCB experience in below the knee, impact deep failed. Obviously, biologics not such a good results. Carpenter data review showed no advantage to drug-eluting balloons below the knee. Another meta-analysis shows comparative data have not shown patency benefit to drug-eluting balloons below the knee. Plutonics missed the primary endpoint. StellarX study was stopped by the sponsor, so we don't know what the results would have been. Impact BTK failed, as we all know. Now, sirolimus balloons are showing some promise, but I don't think it's just drug. The drug-eluting balloons are balloons. We still will fail the recoil and dissection that we talked about. Meta-analysis you've seen earlier on the drug-eluting stents in favor of drug-eluting stents, both TLR restenosis and amputation rate. More recent meta-analysis shows the same type of results, although DCBs were included in this analysis, and all favoring drug-eluting stents. Now, comparative performance analysis in BTK looking at POBA, bare metal stents, DCB, and DES showed again in favor of drug-eluting stents, again, a trend and that becomes a statistically significant for drug-eluting stents. Now, there are limitations. Devices are short. Studies include short lesions, about 4 centimeters or so. Multiple devices could be cost prohibitive, and a lot of us don't like permanent metal stents here and there. So that brings us to bioabsorbable. You saw this data from Dr. Parikh earlier on, that there is some promise in bioabsorbable stents if they can perform the same. And that's the purpose of some of the ongoing studies. So short lesions, we do have a solution. Drug-eluting stents would be used, hopefully at some point bioabsorbable. We've seen this before, that the recoils are very common. Multiple data out there. We reported ours a long time ago. And I want to just end by showing this particular case to, again, show the value of the stents. This patient had a lot of inflow disease that we did treat. That's not the purpose of this presentation. But as you can see, there's popliteal out and reconstitution of the anterior tibial artery and the perineal artery. The anterior tibial artery was recanalized in a retrograde fashion, and so we ended up something like this, okay? So this was treated by drug-coated balloon, the occluded the popliteal, and the other two with drug-eluting stents. And this was done in 2019. This is how we ended. This is what we saw in 2020. You can see the drug-eluting balloon is out. Drug-eluting stents, despite the fact they're hanging on by a thread, are open. This is not just our experience. Other people have also talked about it. You go back in, you see that the drug-eluting stent is open and everything else is closed. And so these will have a role, without a doubt. So we have changed our approach since then, that in these types of occlusions that we saw earlier on Chris Metzger do, that we now are drug-eluting ballooning and stenting the popliteal, drug-eluting stenting the tibials. So role of scaffold below the knee, manage common modes of failure, both early and late. Recoil is usually focal rather than diffuse, and restenosis is diffuse rather than focal. And the combination has got to be mechanical and pharmaceutical. And spot stenting with drug-eluting stents would likely be the solution to that. And we'll see what the role of the bioabsorbable platforms are. Thank you.
All right, beautiful. Thank you.